Have you ever been in the situation clinically when your assumptions were challenged? Maybe the new advance that you thought everyone was on board with, well, you just found someone who didn't get the memo. Knowledge translation is a tricky thing. Sometimes new concepts can spread like wildfire, and everyone immediately knows the latest and greatest. Sometimes they're just little sparks that float a little too high. They never make contact with intellectual kindling. They never set fire. They never illuminate their surroundings. Today, we'll talk about some myths in pediatric emergency medicine. Many of these you'll already be familiar with, but it's one thing to be familiar with or assume that everyone else understands where you're coming from when you have already adopted that practice-changing advance. It's another thing entirely to have that evidence to back it up, the reasoning, the analysis behind it, all at your fingertips.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Today we have a medley of myths to offer. When discussing new concepts with colleagues, it's helpful, I think, to know the background, know where they're coming from, so that we can meet them where they are and take them through the advances to catch up with the cutting edge. Today, we'll discuss atropine for intubation, opioids for abdominal pain, D5-NS for dehydration, epinephrine for allergy, sickle cell trait, steroids for pharyngitis, and adhesive bandages for wounds. You gotta give atropine before you intubate that child. That was the mantra during my training. The idea was that intubation can cause bradycardia and children don't tolerate bradycardia, so voila, here's the solution. Give them atropine before you intubate and problem solved. We felt pretty good about ourselves for a time until more and more research emerged to challenge this dogma. The background is that putting a metal blade down a child's gullet is certainly vaguely stimulating. Hey, just examining their throat with a tongue depressor can do this too. Also, some of the medications during intubation can cause a transient bradycardia. It is drilled into us, of course, that bradycardia in children is ominous. And that's true if we're talking about the bradycardia associated with poor oxygenation or in shock states. So, why not tick up the heart rate ahead of time, just a few extra beats? Well, it turns out not only is prophylactic atropine before intubation not necessary, but in fact, it may be harmful. First, we have better evidence now to show that relative bradycardia associated with intubation in children is short-lived and almost never progresses to a dangerous dysrhythmia or to hemodynamic compromise. Second, the tachycardia caused by atropine consumes oxygen. Remember, we're doing everything we can to pre-oxygenate and quickly pass that tube because this hypermetabolic child is eating up oxygen stores in this hopefully brief apneic period. Ramping up his metabolism with atropine just at this vulnerable time is counterproductive. Third, there never really was any clear evidence to start this practice of prophylactic atropine in the first place. It was eminence-based medicine, not evidence-based medicine. And fourth, it just complicates an already high-stakes procedure. don't go adding more to the stew than you need. In case you were still wondering, well, what if my little patient does have some relative bradycardia during intubation? Maybe I'm just getting a view of the epiglottis when someone yells out, "The heart rate is dropping!" First, don't be that person. Second, it's airway first for a reason. Keep your eyes on that prize and pass that plastic. Because once you do that, you can easily just follow what the pediatric advanced life support algorithm would just tell you. Bradycardia with a pulse in PALS is addressed with oxygenation and ventilation. So you do that and all is well. Remember, of course, that if your patient continues with a heart rate below 60, with poor perfusion, even with a pulse, we start CPR. This is going to be an uncommon thing. After oxygen, then you can go to epinephrine, and only then can you consider atropine if you think there is prolonged vagal tone or some associated AV block. Just keep it simple. You can have atropine at the bedside if you like, but resist the urge to give it before you need it. It's a medication, not a placemat. Okay, I will give you one caveat just to up your game. Let's say you happen to use succinylcholine as your paralytic agent for your, say, 3-year-old who fell out of a window with major head trauma and has an irregular breathing pattern. You give the sucks, the airway is full of vomit, and after some attempts, the sucks is wearing off. Do you, A, intubate through whatever conditions you have, B, stop, bag the child, and give another dose of succinylcholine, or C, something else? Well, what would you do? I think that you have to make a decision with the best info that you have at the time. But I will say, if you choose your own adventure and open the door with another dose of succinylcholine behind it, that may just be your only way out. But don't be surprised if the patient gets worse in front of you. Why do I say that? When you give a depolarizing agent, such as succinylcholine, you target the nicotinic receptors to achieve paralysis and loss of muscular tone so that your visualization is optimal. With a second dose of succinylcholine, you're going to saturate all receptors, not just the nicotinic receptors, but also the muscarinic receptors, which will cause the dumbbells phenomenon, including bradycardia and bronchorrhea. That effect is not so transient. You may just need atropine to rescue you from the toxic effects of succinylcholine overdose. My practice is to avoid a second dose of succinylcholine altogether in adults or in children, either by switching to rocuronium, a non-depolarizing agent, or just starting with rock in the first place. You may hear this one. Don't give opioids to patients with abdominal pain. The surgeons won't be able to evaluate them. Do you ever wonder where this nonsense started? Well, it was established dogma until not too long ago. Generations of physicians learned that morphine will take all of the pain away, and you can't tell if the patient has a surgical belly. This was codified by Sir Zachary Cope in his Cope's Acute Abdomen, which, after several editions, is still read by budding surgeons. In 1921, more than 100 years ago, y'all, he states, I quote, "All opioid pain medication should be withheld until a firm diagnosis of the patient's abdominal pain is made." Okay, this gave the impression of the surgical gatekeeper. It wasn't until 1996, 75 years later, that the newer edition changed that to, quote, not until a responsible surgeon sees the patient. Really? Only in 2001 was yet another update that this was, quote, an unfortunate dictum, unquote. In the meantime, the attitude is still pervasive. What were they thinking we should do for someone suffering in pain from appendicitis? Oh, sorry, we need to wait for the responsible physician. As emergency physicians, we are the ultimate patient advocates, and we pushed back on this. We pushed back hard. In 1992, Attard et al. Were able to establish that in adults, opioids before surgical consultation were indeed safe, and they did not delay diagnosis. In 2005, Dr. Green offered evidence of the same in children. In 2011, a Cochrane analysis, that same Cochrane group, about whom I like to lovingly say that they never find a positive finding, even the skeptical Cochrane group found that opioids before a surgical consultation is safe for everyone. It doesn't mask the diagnosis, and it does not delay it either. I would add that in addition to just being a good doctor and a good human being and reducing suffering, giving the pain medication may actually help with the exam. It may improve your specificity. Take off the excess symptomatology, even that hesitation that the patients might have when you're trying to examine them, so that it'll help you pinpoint exactly, well, yes, this boy with fever, vomiting, and abdominal pain is in fact exquisitely tender in the right lower quadrant and nowhere else. Here's another myth. You can't bolus D5NS. Now, to resuscitate, use normal saline or lactated ringer solution or whatever your resuscitative isotonic solution of choice is. What I'm talking about now is the poor child who is the miserable vomiter. He is already dehydrated when he comes to you for his likely acute gastroenteritis. You normally try the antiemetic, you try Zofran or Danzatron, he keeps vomiting, he remains dehydrated, and so you have to fall back on potentially putting an IV in. Now, this is, of course, the minority of cases. You can get very far with small sips for oral rehydration, and that's always better if you can rehydrate them via the mouth. But there are times when you got to go in and break that cycle and rehydrate the child with IV fluids. So you could give normal saline, and of course that would help. All of that time, that child hasn't had any real source of energy, and for sure is building up ketones, a mild starvation ketosis. Why not break that ketosis with some dextrose while you are fluid repleting them? Now, I can see where people are coming from when they question this order. It's usually ordered for maintenance with an ml per hour option. And the truth is, if anyone questions an order, it's always pays to take that moment to see where that person is coming from. Sometimes it truly is a mistake, or there are other options, or just a chance to gain a believer. The real issue is the concentration of dextrose in a solution, which can be irritating to veins and even cause sclerosis over time. This is why we give a dilute solution of D10, so only 10% dextrose, to infants younger than 1 year of age. We give D25 to toddlers and preschoolers and young school-age children, and D50 to anyone older than 8 years of age. We give it because we have to, and we push it. Now, let's go into the evidence behind D5NS. D5NS means dextrose 5% in normal saline. Okay, for this, we'll assume that 1 gram of solution is 1 ml, 1 milliliter, so 5% by weight or volume of dextrose is 50 grams. D50 is a solution we give all of the time as a push to older children, adolescents, and adults for hypoglycemia. It is D50 because it's a 50% solution of dextrose. The 50 ml ampule contains 50% dextrose, so that ends up just being 25 grams of sugar. So D5NS is basically 2 amps of D50 shot into a bag of NS. D5NS is the most dilute version of dextrose available. The dextrose in it will not sclerose veins, and we know that there's no problem giving normal saline as a bolus, so why not do both? Your vomiting child who is otherwise stable but miserable will feel much better, much faster. Next myth. You gave epi? Oh, we gotta keep them. This one I think is slowly going away, but it's important to go over why. The traditional teaching was that anaphylaxis treated with epinephrine should be observed for at least 4 to 6 hours because there may be a rebound phenomenon. That is, once the epinephrine effect is gone, the cytokines, inflammatory mediators, and immunologic cascade will come roaring back and cause a rebound effect and anaphylaxis all over again. This got people so worried that children stayed in the ED for long periods of time, and I would add my own personal observation. I think the idea of having to keep someone may have influenced who got epinephrine in the first place. With good intentions, some clinicians may not want to commit the child to a protracted stay if, well, those hives don't look that bad. He isn't really breathing that hard. He only vomited once. You see what I mean? We all know that allergists, general pediatricians, and emergency physicians, all alike, everyone, we under-recognize, we underdiagnose, and we undertreat anaphylaxis. This has been studied across the board. Now, of course, allergy and anaphylaxis is a spectrum, but if the thought crosses your mind, is this anaphylaxis? It probably is, if not just a mild form. Go ahead and treat it. It's better to be aggressive early and avoid complications. We give epinephrine intramuscularly, always in the muscle, and really it's just fraught with error if we even try to give it IV. In fact, it ends up being more slowly given IV because you're trying to be extra careful. Just jab them in the lateral thigh. It's safer and it's faster, no matter how sick you are. 0.01 milligrams per kilogram up to the adult dose of 0.3 milligrams. The auto-injectors are just fine to give even in the ED as long as the dose is approximately correct. The junior auto-injector is 0.15 milligrams and is for children 15 to 30 kilograms. The adult auto-injector is for anyone 30 kilograms and up. So once you reach 15 kilograms, you get to use the 0.15 milligram dose, that junior version. Once you get to 30 kilograms, you can use the 0.3 milligram dose, the regular version. The right answer is always an exact milligram per kilogram dose. So in the ED, I encourage you, if you have time, to pull up the right dose for anybody, especially those under 15 kilograms. You may want to be a little extra careful for those under 15 kilograms, not so much because of a minor relative overdosing, but more because their tissues just don't do well with auto-injectors. Now, for example, in an infant, the auto-injector to the lateral thigh can propel into the tissues past the muscle and into the femur, making it an IO dose an intraosseous dose, which is equivalent, of course, to the IV route. And what did we say about the IV route for epinephrine and anaphylaxis? Not today. All right, so your patient has anaphylaxis, and the nurse says, hey, we already have an IV. Why don't we just give it that way? Survey says, no, wrong dose, wrong route. These doses are specific to the intramuscular route. It is always the preferred route, regardless of whether you have an IV, IO, central line, always intramuscular for anaphylaxis. Okay, so you've given the epinephrine IM. The onset of action is 8 minutes, give or take 2 minutes. The child looks and feels better. So now, how long do you wait? The half-life of epinephrine given in the muscle is approximately 45 minutes. So if you wait 2 half-lives, then it's metabolized. That ends up being about an hour and a half. If this were a mild case and you knew exactly why it happened, there's a specific etiology, there's a specific precipitant, the child as well, you may not need to wait much longer than that. If, however, the child is known to have severe reactions, you may keep him around a bit longer. If this were due to a nut allergy, maybe wait a bit longer than that. Allergic reactions to tree nuts tend to be severe and worse with each exposure. If your child has asthma or atopy or allergies in general, then it's just fine to hold on just a little bit longer. But knowing the pharmacodynamics and pharmacokinetics of intramuscular epinephrine can really be a boost to you and your patient. And we know that the onset of action of intramuscular epinephrine is 8 minutes, give or take 2. And the half-life of intramuscular epinephrine is 45 minutes, give or take 5. So 2 half-lives is an hour and a half. Keep them for 2 hours, everybody's happy. Anybody else more complicated? Hang on a little longer. Sickle cell trait, that's nothing. You've probably heard this one before. Now, it is true that sickle cell trait is not sickle cell disease, and we don't see the same baseline morbidity and mortality. Pain crises with daily activities just don't happen to those with sickle cell trait. This is an autosomal recessive inheritance. So someone who is suffering from sickle cell disease has received the recessive trait from both mother and father, the hemoglobin S gene. In someone with sickle cell trait, one of the parents gives them hemoglobin S, but then the other has an overriding autosomal dominant hemoglobin A, hemoglobin adult. So what happens is the result is an overwhelming majority of hemoglobin A, hemoglobin adult, regular functioning hemoglobin, with some small quantity of hemoglobin S formed, usually in very negligible numbers, and doesn't hurt the person with sickle cell trait until something happens to them. Some extreme physiologic stress, extreme environment, maybe very high or very low altitudes, or critical illness. All of these things can cause that small amount of hemoglobin S to sickle and cause a vaso-occlusive event. There is a case report, one of many, that illustrates this point. A 15-year-old boy was at football practice in the summer heat. He was playing hard. He didn't feel well later on in that day, and he was brought into the ED because he just was so dehydrated, so tired. It looked like for all the world to see that this was heat exhaustion. They found him to have metabolic acidosis and rhabdomyolysis. Now, I'm not sure whether it was known at the time he had sickle cell trait or not, but everyone did the right thing. He was admitted, and he was treated, he was hydrated, and he died 24 hours later. what happened. One day prior, this boy was the picture of health and fitness. He suffered what is called ECAST, exertional collapse associated with sickle cell trait. Those with sickle cell trait have a 37-fold risk for exertional collapse, and the mortality is real here. This was such a problem, such an issue, that the National Collegiate Athletic Association, the NCAA, enacted a screening program for those athletes at risk. Before the intervention, the rate of ECAST was 1 in 28,000, so uncommon, but deadly and potentially preventable. After the screening, the rate of death associated with sickle cell trait was 1 in 250,000, 1 in 250,000, an 89% relative risk reduction. Amazing. Sickle cell trait is something that should get your attention when you see a sick child or an adult for any reason. Usually people know that they have sickle cell trait and they'll readily tell you, but you may elicit it on past medical history or family history, sometimes with patients who come in for syncope or for other undifferentiated illness. I might ask them, just very matter-of-fact tone so we don't scare them, did anyone in your family die when they were very young and we don't know why? Sometimes the answers may surprise you. Sickle cell trait later in life is associated with recurrent pregnancy loss, coronary artery disease, atrial fibrillation, and chronic kidney disease. Physiologic stress in children with sickle cell trait. Watch out for morbidity and mortality. Next myth. You have a child with pharyngitis? No steroids for you. This one needs a little unpacking. In adults, we love to give steroids for pharyngitis. It makes people feel better faster, it gets them back to work, and it's just a one-time dose of Decadron. It's fantastic. In fact, they'll thank you more for the steroid than any other antibiotic effect. This is in stark contrast to what we've been told in treating children with sore throat. The old teaching was that recurrent or indolent pharyngitis in children could be a presenting sign of acute lymphoblastic leukemia. It's a rare presentation. Leukemic tonsillitis is a thing, but maybe somewhat overrated. Let's explore. In emergency medicine, we love to be right. We love to nail a diagnosis. Who doesn't? It warms the little high-achieving cockles of our hearts. But sometimes, you know what's even sweeter? Not to be wrong. We sometimes play to win, and sometimes we play just not to lose. The throat can be a bit of a black box. We don't want to miss cancer or an abscess, but we don't want to overtreat everyone either. When you advance that tongue blade back and just barely gag that toddler to elevate his palate, you get a look for just a second. Or when you finally convince the teenager that she has to stick out her tongue and say ah. No, really, say ah. Opening the mouth doesn't count. Say it. Say it. Why won't you say it? When you get that flash of a look at the anterior pillars, the tonsils, the hypopharynx, you have to make a quick assessment. What's edematous? The pillars, the uvula? Do I see exudate? Is there palatal petechiae there? Maybe I see a hot red pharynx with exudate. Looks like strep in the right patient. Maybe I just see mostly erythema, not much edema, not much exudate. Maybe this is viral. Maybe I see not much edema or erythema, just a gray-white pseudomembrane over the palate and extending into the tonsil in a partially vaccinated person. And I think diphtheria, is that you? Anyway, the point is, make your diagnosis of pharyngitis to the best of your ability. Do a good head and neck exam. Make sure you treat the underlying problem. If you're worried about leukemia, maybe the sore throat has been going on for a long time, or maybe it's already been treated a couple times, the patient's not better. Maybe there are more other prominent things like lymphadenopathy. Maybe overall the child feels fatigued, and it's just enough altogether to make you wonder, is this leukemia? Then go after that diagnosis. Go for it. The only danger here is that if we throw steroids at everything, that one time it is leukemia, we can be very, very wrong. The danger here is that if we throw steroids at everything, the one time it is leukemia, we can be very, very wrong. Steroids are one of the medications we use in the induction treatment of leukemia. We could accidentally treat a cancer when we think it's just strep. This would lead to a delayed diagnosis and potentially morbidity. So that's the background. The consideration that turned into dogma, turned into a myth. No steroids for pediatric pharyngitis. But is that fair? Well, let's look at the evidence. In terms of safety and efficacy of steroids for acute pharyngitis, in 2003, Bullock et al. Found there was no difference in symptomatology whether you gave it or not. In 2010, Wing et al. Found a small treatment effect, a little blip. In 2012, there were reported findings of clinical efficacy, especially when the child has group A strep. In 2017, Sedegarad found that steroids are beneficial. And finally, a Cochrane review in 2020 found in their meta-analysis that children who were given steroids for pharyngitis were 2.4 times more likely to have a resolution of symptoms in 24 hours. So that's pretty good evidence. My take on all of this is that, yes, we should always be careful. Make your diagnosis first, the etiology of the pharyngitis. But don't be held back by unnecessary fear. If the child has severe symptoms, he has difficulty in tolerating secretions, difficulty eating, especially if he's strep positive, then go ahead and give a dose of dexamethasone. He'll feel better faster. And our final myth for this installment, finger injuries? Self-adhesive dressings should be fine. Coban, go for it. I mean, it is tempting. Children injure their fingers, fingertips, hands, toes all of the time. It is very hard to keep a Band-Aid or a dressing or tape or anything on the fingers of a 2-year-old. They just don't stay. Let's consider a case. Grayson is a 2-year-old boy who was playing in his father's garage when a heavy metal object fell on his right hand. He sustained a few lacerations to his index and middle fingers. He was brought into the ED. They repaired him very nicely. Grayson was not happy about the day in general that he was having, and he was pulling off all the dressings as he put them on. So with good intentions, a self-adhesive bandage was applied to help keep the wounds clean. You know those elastic gauze rolls that adhere to themselves? They work wonders for, let's say, a venopuncture in the antecubital space of an elderly woman on blood thinners. Just keeps it nice and tight. A trade name is Coban, but the self-adhesive elastic bandage was applied to Grayson's fingers in an attempt to help the parents care for them. They were instructed to change the bandage at least twice a day, clean it with soap and water, assess the wound, apply ointment, the usual. Well, the parents changed the dressing maybe once in 10 days before the return visit, and probably just before they returned. At least that's what the report was. The child came back with mummified digits. They looked like dry gangrene, or if the child's fingers were 1,000 years old. desiccated, atrophied, dead. Needless to say, he required amputation of the index and middle fingers of his right hand. Sobering, to say the least. What happened? Well, these self-adhesive, flexible, elastic bandages are great for temporary hemostasis. They probably slowly over time caused ischemia to poor Grayson's fingers to the point where he stopped having pain. There is case report after case report after case series after case report of pediatric digital necrosis after self-adherent elastic wrap. Even if you were tempted to do this in some capacity, the case against it is just so well laid out. It feels indefensible. Now, that isn't to say that these self-adherent dressings don't have their place. I would argue in the very acute setting, in the ED themselves, but really never to go home with in an adult or a child. But that's just my extrapolation. I can say very clearly that we should not be placing these self-adhering dressings to fingers, and definitely don't send them home this way. What to do? If the child is young and you know that the dressing will just pop right off that finger, then why not turn that finger dressing into a fluffy mitten? Directly on the wound, you can place Vaseline gauze, some kind of ointment-based gauze, and petroleum-based gauze, then dry gauze. That way, when you're doing the dressing change, it's not a wet to dry change. You don't pull off part of the healing tissue with the dry gauze. So, say the wound is on the fingertip. The fingertip gets the Vaseline gauze, then dry gauze over it, then place a layer of gauze between that finger and the next, and then use a gauze roll to make a cool mitten. Wrap that fluffy gauze roll around the fingers, anchor it around the base of the thumb, around the wrist. Make yourself a loose gauze roll mitten. The single layer of gauze between the fingers just prevents maceration. So, self-adherent dressings are tempting, but they will burn you. Never on fingertips, and really, I would say never on children at all. Medicine is always changing, and so should we. Sometimes when we know a little bit about a subject, we like to hold on to what we know. It's a comfortable anchor. So, hey, me and you, let's make a deal. Let's be on the lookout for the new understanding of disease that comes out. New ways, better ways, more evidence-based ways to evaluate, to treat, so we can update our own personal databases. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.